Good day. My name is Michelle Lavander. I'm the founding director of the USC Annenberg Center for Health Journalism. Thank you for joining us for our Health Matters webinar, The Next Wave of America's Overdose Crisis. Fatal overdoses are skyrocketing in America as illegal fentanyl floods the streets. And that's changing the face of the epidemic. The crisis, which first garnered attention in white rural America, is hitting hardest today among people of color and teens and young adults. The death rate is escalating twice as fast in the Black population as compared to white people, and it's rising more rapidly among adolescents. For Black teens and young adults, overdose deaths jumped a staggering 86% from 2019 to 2020. This crisis also is no longer solely about opioids or addiction. Fentanyl and other poisonous synthetics are often mixed, undetected until it's too late, into cocaine, methamphetamines, and popular party drugs like ecstasy. The Biden administration has made historic investments in prevention and harm reduction. It's prioritized drug seizures. In 2021, the DEA seized more than 15,000 pounds of fentanyl powder, enough to kill every person in the US. But more must be done. Here to help us understand the shifting patterns of the crisis, the barriers to services and treatment, and fresh reporting angles, we have three distinguished panelists. Magdalena Cerda is a professor in the Division of Epidemiology of the Department of Population Health at NYU Grossman School of Medicine. She also directs the school's Center for Opioid Epidemiology and Policy. And we'll hear from two award-winning journalists, Scott Hyam and Sari Horowitz, who co-authored the Washington Post Opioid Files Project, a 2020 Pulitzer finalist, and the 2022 nonfiction book, American Cartel, Inside the Battle to Bring Down the Opioid Industry. Welcome, Professor Cerda, Scott, and Sari. This webinar is made possible thanks to the generous support of the National Institute for Healthcare Management Foundation, the California Endowment, and individual supporters like you. A word about our format. We'll be hearing from our speakers first, and then we'll turn it over to our audience for your questions. Feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers in the Q&A panel. And you also can write us there if you're experiencing technical problems. We'll be archiving this conversation later today at centerforhealthjournalism.org. Now let's get underway. Scott, please set the stage. You've been reporting on the opioid epidemic since 2016. What are you seeing on the ground these days, and how do we get here?
Well, first of all, thank you so much for having us. And it's a true honor to speak to the next generation of great journalists out there. And so thanks for doing this. It's so important. Sari and I have done a lot of things in our career and investigated lots of nefarious companies, politicians, etc. And I think this is one of the most horrible things we've ever witnessed as journalists in our careers. To kind of understand how we got to where we are, I think it's really important to look at the origin story of the opioid epidemic. And today, more than 200 people are dying every single day from fentanyl overdoses. That's the equivalent of a Boeing jet crashing and killing everybody on board every single day. Another way to look at it is it's the leading cause of death for adults between the ages of 18 and 49, so most of you out there. And that's kind of a shocking turn of events in American history. This all began, a lot of people know about Purdue Pharma and the Sacklers and OxyContin, which was introduced in 1996. But what a lot of people don't know is 10 years later, the federal government cracked down on Purdue. It fined the company. It ordered them to reformulate OxyContin to make it much more difficult to abuse. And OxyContin was nothing more than just oxycodone, a straight up opioid that was time released. And the idea for Purdue was that because it was time released, it wouldn't be addictive. Well, that wasn't the case. But anyway, Purdue got into trouble, and a lot of companies in America saw that there was a market for a lot of companies to jump into. And they began to manufacture far more drugs than Purdue Pharma could ever imagine. And Sari and I began to look at internal documents, internal data from the DEA, And what we started to see was, there were a lot of companies that were household names: Walgreens, Walmart, CVS, Johnson & Johnson, that were involved in the trade, but also involved in the trade were companies that we never really even knew existed or knew very little about. And one of them was named Mallinckrodt. It's one of the oldest pharmaceutical companies in America. It's based in St. Louis. And they began to manufacture a 30 milligram pill. It was blue in color. It had an M on one side and a 30 on the other. It was the equivalent of a hit of heroin. And that pill became the most popular pill in the black market in the United States. And all across the country, people were going down to Florida, getting prescriptions for these pills from corrupt doctors, corrupt pill mills, and then bringing those prescriptions up north, getting them filled. And that path between South Florida and the corrupt doctors and the pill mills and Appalachia at the time was called the Blue Highway, because it was basically paved by these blue pills that were highly addictive. And they became super popular, and that'll become important in a second. And so these companies started getting into a lot of trouble, and towns and cities, tribal nations, counties began to sue them en masse. There were as many as 4,000 lawsuits against 24 companies. It was the largest mass tort in American history. And a lot of these companies changed their conduct and behavior. It was so much harder to get prescription pain pills on the street, and it left tens of millions of Americans addicted to opioids with no place to turn. At first, the Chinese criminal gangs and drug trafficking organizations saw an opening, and they started shipping fentanyl into the United States through the dark web. And then the Mexican drug cartels began to send heroin into the United States, which is the second wave of the epidemic in America. But heroin really never took hold as firmly as prescription pain meds. It's a dirty drug. You have to inject it. It's expensive for the cartels to manufacture. You have to cultivate poppy plants. You have to smuggle it. It's hard to smuggle. And they quickly realized that the Chinese were onto something, and that they were going to take over that market and start manufacturing fentanyl. And fentanyl is the same molecular structure as heroin, as oxycodone, as OxyContin, as all these painkillers. They're all derivatives of the opioid plant, the opium plant. But the only difference is that fentanyl can be mixed up in a bathtub instead of in a field where you have to grow, plants. It takes very little to make. It's really cheap to make. It's super easy to smuggle into the United States, and it is incredibly profitable. It's the most profitable drug that the cartels have ever made in their history. And so they started flooding the United States with fentanyl. And their go-to product, they took a page right out of the US drug industry. Their go-to product is a blue pill that has an M on one side and a 30 on the other, and it's a counterfeit Mallinckrodt 30 milligram pill, except for they're filled with fentanyl. And those things are all over the country. And so the US drug industry had basically set the table for the cartels and created a market for them. And Sarah and I have traveled around the country and spent a lot of time in areas that have been just devastated by these drugs, towns that have been hollowed out. At first, it was small towns in Appalachia, and Ohio, and West Virginia, Kentucky, New Hampshire. Then it became big cities, Chicago, New York, San Francisco, LA, San Diego, places that you would never expect to be walking downtown and walking into a place that looks like a set from a zombie movie. And we spent a lot of time this past summer on the southern border with U.S. Drug agents and also local and state police officers who are trying to save lives with Narcan, because that's the only thing that they can save lives with. It's an amazing drug. It reverses overdoses, and also trying to stop the flow of fentanyl into the United States. And that's a task that they have found to be completely impossible. They are overwhelmed, they are beleaguered, they are sad, they can't do their job, and all around them people are dying. We want to show you just an edited version of a longer documentary that one of our colleagues, Aaron O'Connor, did for the Washington Post for a project that we called Cartel RX that ran in December. I highly recommend watching the whole thing, but we're going to show you just a short clip of it.
I'm the field lieutenant. I work nights from 4 p.m. to 4 a.m. I monitor everything that's going on in the city, and when there's a hot call, something that's high risk, or a call where we're going to have a lot of police officers there, I'll monitor those, or I will actually go to the scenes. So from my experience, when somebody overdoses on fentanyl, they'll drop very soon after they've used. They may not even know that they took what they took. When we have little blue M30 pills, people think that those are pharmaceutical grade pills, when in reality they're pressed in somebody's garage or in a warehouse somewhere. So this is a death call. Usually when we get a call like this, it's someone who's overdosed. When you guys got here, medics got here at the same time?
I showed up with fire, medics came after.
Okay.
Sorry, fire.
And who gave the first Narcan?
I'm not too sure, to be honest with you.
All of our officers now are issued Narcan in 4 milligram doses. Narcan's like the miracle drug. I mean, that's the one chance that they have of survival.
I thought it was like one of those fake Oxycontin pills.
The blue ones?
Yeah, that's what
Yeah,
I
30s.
thought it was.
Okay. Did you take some?
No, I just smoke weed.
I'm asking because I'm concerned.
I'm just really happy.
Do you know if there's any more of those pills here at all, so we can get rid of them?
I don't think so. She went to the bathroom, had her fun, and pretty soon after that, I called the agency. I was
Good.
like,
Good
she
for
was
you.
unresponsive, and I was like, I'm not gonna f around.
So I'll tell you this, you saved her life. Okay.
Thank you.
They can inject it, they can snort it, they'll take a piece of tinfoil, they'll put it on there and they'll light it underneath, and they'll inhale the burn from that. The deadly dose of fentanyl is so small that in that 30 milligram pill, you just don't know how much actual fentanyl is in there.
Thank you, Ryan. So, I mean, that scene is playing out in every town and city that Sari and I and Nick Miroff and a lot of other people at the Washington Post have worked on this project for a long time. We see this scene over and over and over again. It's simply heartbreaking.
Thank you so much, Scott. Really a very troubling portrait with this video. We're going to turn now to Professor Cerda. Scott has just painted a very grim portrait of what he's seen on the streets. And as a researcher, can you take us behind the scenes to understand the data? Who's being affected? What disparities have you documented on access to treatment? And what's the adequacy of the policy responses in the face of this crisis?
Thank you. Thank you for giving me the opportunity to talk to you guys today. I think this is actually a really nice coordination of content across the three presentations. So my talk is going to really focus on three things and put some numbers behind exactly the kind of information that Scott just presented. So first, reviewing some of the trends in overdose in the United States. Then talking about some of the work that my team has done on what works and what the issues are with program and policy responses to the crisis. And then finally offering some insights about what we can do as next steps to address this crisis. So unfortunately, the United States is not only in a national crisis, but it's actually a global leader in opioid overdoses. This is a graph showing you opioid overdose death rates for some of the countries with the leading rates across the world. And you can see that the United States is far and away the one with the highest rates. And this problem is only increasing in the United States. So Scott talked about these three waves of the opioid overdose crisis, starting out with the rise in overdoses involving prescription opioids that you can see here in the green, followed by a rise in overdoses involving fentanyl when the prescription opioid supply became tightened and heroin was introduced with a lower price and higher purity into the market in blue. And then finally followed up by what's the third wave, where we are today, which is really driven by the introduction of fentanyl and other illegally manufactured synthetics into the illegal drug market. And that's the purple line. So traditionally, at the beginning of this current crisis, it was conceived as more of a rural and white problem affecting whites and American Indians and Alaska Natives. But the profile of the epidemic has really shifted as the types of drugs involved have also shifted, so that today, actually the groups experiencing the greatest increase in overdoses are Black Americans and American Indian Alaska Natives, to the point that if you stretch this timeline further out to the current time, the rates among Black Americans and American Indian Alaska Natives have surpassed those of whites. The overdose crisis got worse with COVID. This is a graph showing you the number of drug overdose deaths both before and right after the start of the COVID-19 pandemic. And you can see that there was a peak at the beginning of the pandemic. Now it leveled off afterwards, a few months after the start of the pandemic, but still the numbers remained higher than they were prior to the pandemic, to the point that in 2021, more than 100,000 people died of an overdose, mostly involving opioids. And that was the highest number ever in recorded history. So while the overdose crisis is really driven by opioids, most of the overdoses involve opioids, it's also increasingly a crisis involving polysubstance use. That is, particularly opioids in combination with other drugs, particularly stimulants. We were interested in looking at trends in overdoses involving opioids and stimulants and how those evolved over time across the United States and for different racial ethnic groups. And so here I'm showing you data for overdoses involving opioids with cocaine, and I'm also going to show you data for overdoses involving opioids with psychostimulants, in other words, methamphetamine. And so here I'm showing you maps in two time points, 2007 and 2019, for whites and for Blacks for each US state. Darker means higher rates. You can see that for both whites and Blacks, the rates of overdose involving cocaine and opioids have increased over time, but they've increased substantially more for Black people than for white people. A similar trend is seen for overdoses involving opioids and psychostimulants, or in other words, methamphetamines. Again, a huge rise in these types of overdoses, both for whites and for Blacks, but much higher rise for Blacks than for whites. So again, this is a problem that is increasingly affecting racially minoritized communities, and it's a problem that is getting worse every day. Now, there are, at the beginning of the overdose crisis, really the focus of the response focused on regulating opioid prescribing and tightening the prescription opioid supply. But now what we're talking about is a crisis characterized by particularly illegal opioids. And so because of that, really the focus has, in terms of the response, has to shift. And there are two areas where I would say the focus needs to be most urgently placed, and that is harm reduction and access to evidence-based treatment to treat opioid use disorder. In other words, to treat opioid addiction and to reduce the demand for opioids. So there's a lot of effort being invested right now in these two types of responses. I'm just going to briefly talk about some of the data we have on these two types of responses based on our own work. So first, talking about harm reduction. So harm reduction, what we're talking about here is really meeting people where they are in their lives and treating them with dignity and giving them the tools they need so that if they are to consume drugs, they can do so safely in a way that prevents health problems associated with drug use and in a way that prevents death. One of the major tools in harm reduction, as was mentioned by Scott, is naloxone. And so naloxone, as was shown in the video, can be used to reverse overdoses and thus prevent people from dying from overdose. So given how important this is, you would think we would need naloxone to be widely spread across the United States. So we looked at how widespread was naloxone access across the United States. And I'm going to be presenting two maps. So here, this first map shows you the county community-based naloxone programs per 100,000 in 2022 across US counties. So these are programs that are community-based, and one of their missions is to distribute naloxone. And so darker is higher, and the light green means there are no naloxone distribution programs. And so essentially only 15% of counties in the United States in the present day have community-based naloxone distribution programs. Now, another way that people might access naloxone is through substance use disorder treatment centers that distribute naloxone. So we also looked at the distribution of county treatment centers that provide naloxone. And again, we saw huge gaps, and indeed less than 50% of treatment centers less than 50% of counties have treatment centers that provide naloxone. So essentially, broad swaths of the United States lack access to some of the leading sources of naloxone for community-based use. The other issue with naloxone is that access to naloxone is inequitable by race ethnicity, where essentially what happens is that white individuals compared to, for example, Black individuals, but the same would be with other racially minoritized groups, white individuals are more likely to receive training in naloxone use, to access naloxone through community programs or prescriptions, to obtain a naloxone refill, and to use naloxone. This is particularly tragic and particularly critical given that what we're seeing about the particularly increasing rise in overdoses among racially minoritized groups. Another leading harm reduction strategy adopted by US states and local jurisdictions is what are called Good Samaritan laws for overdose response. And those Good Samaritan laws would actually have been applicable in the video shown. What these laws are intended to do is they're intended to protect bystanders who call for help in case of an overdose, to protect them from being charged for a drug-related crime. And the idea is that if they're protected from being charged, then more people are likely to call for help. And so there's going to be a faster response in case of an overdose. However, not all Good Samaritan laws are created equal. In fact, states vary widely in terms of the level of protection that they provide to bystanders. So whereas in some states, bystanders are protected from being arrested in case of an overdose, in other states, they may still be arrested, but they may be protected from prosecution, or their sentence might be mitigated. So you can imagine that the level of protection will really determine whether people are likely to call for help. And indeed, in some work that we did, we found that the only type of Good Samaritan law that was actually associated with a decline in overdose were those Good Samaritan laws that protected bystanders from arrest. So really that we need to provide people with the broadest possible protection in order for these laws to be effective. So that's some of what we know about harm reduction efforts among a much larger toolkit in harm reduction. Now, the other leading area of response, again, is improving access to evidence-based treatment. And so really, when we're talking about evidence-based treatment, we're talking about medication, the use of medication to treat opioid use disorder, particularly buprenorphine, methadone, and less so in naltrexone. We know from multiple studies that these drugs are highly effective at treating symptoms of withdrawal from opioids and at preventing overdoses. So you think this is a highly effective tool. we have a horrible problem in this country, you'd think then there would be broad access to medication to treat opioid use disorder. However, access to medication remains a huge challenge. We estimated the number of people who met criteria for opioid use disorder. That's the topmost line in our graph, and then compared it to the number of people who are actually getting medication-based treatment for opioid use disorder. That's the bottommost line. And so essentially we found that 87% of people with opioid use disorder do not receive evidence-based treatment. So this is a huge issue. Again, we are particularly concerned about racial ethnic disparities in treatment. And again, the same as we found for naloxone, we find for opioid use disorder treatment, where use of opioid treatment is lower among racially minoritized populations, particularly Blacks, Native Hawaiian, Pacific Islander, and Asian Americans, and Hispanics. One of the things I really care about is thinking about what kinds of policy levers we can push and we can promote to effectively increase access to evidence-based strategies to reduce overdose. And so for treatment, one of the strategies that seemed to be effective at increasing access to treatment was Medicaid expansion. So prior studies have shown that states that expanded Medicaid coverage actually experienced a much greater increase in buprenorphine. That's the red line denoted by the arrow, and buprenorphine is one of these evidence-based treatments for opioid use disorder. We were interested in seeing whether Medicaid expansion was also associated with a decline in overdoses. If it increased access to treatment, would that trickle down to preventing overdose? And what we saw is that indeed, states that expanded Medicaid not only experienced an increase in access to treatment, but they also experienced a decline in overall opioid overdoses, particularly overdoses involving heroin and illegal manufactured synthetics, suggesting again that Medicaid expansion is an effective strategy. So I've given you some data on the trends of the current response and what we know about the trends in the problem and what we know about response. I've also, one of the questions that I get asked a lot is, well, what are we going to do? This is a horrible problem. What can we do? And so colleagues and I actually have a blog forthcoming in Health Affairs where we put forth suggestions for action. In the interest of time, I'm not going to go into these in detail, but I'm happy to talk about them in the Q&A. Essentially, we call for action in the immediate term, particularly focused on expanding access to harm reduction services. In the medium term, focused on expanding access to evidence-based treatment for opioid use disorder. And then in the long term, really focused around primary prevention that needs to focus on preventing future addiction and overdoses so that this problem doesn't keep happening. To put it all together, opioid overdoses pose a huge and increasing public health problem, and it's an epidemic that's shifting and it's increasingly affecting racially minoritized populations. To address this crisis, I think we really need to invest in harm reduction, evidence-based treatment, and primary prevention. And we need to pay close attention to reducing racial ethnic inequalities in access to these prevention efforts. Thank you so much.
Thank you so much, Professor Cerda. Before we turn to Sari, I just wanted to follow up and ask you to say a quick word or two about something you touched on, which is disparities in the type of treatment. Could you say a quick word about methadone, which you've shared has been largely what's offered to people who are Black, and some of the other more, newer treatment options and the burden on those populations?
Yeah, that's actually a really interesting and important point, which is that so there's buprenorphine. The two leading approaches are buprenorphine and methadone. Buprenorphine, you can get a prescription from your doctor, and you can consume it at your home at your leisure. Methadone, you have to go into the clinic, especially at the beginning, often every day, and it's a very highly punitive setting where you have to where you consume these medications. access to these two medications is really racially segregated, so that neighborhoods with a higher proportion of Black and Hispanic residents have more access to methadone, but lower access to buprenorphine, whereas neighborhoods with higher proportion of white residents have more access to buprenorphine. So again, there's real racial inequity in the types of treatment and the flexibility of treatment that racially minoritized populations can access compared to whites.
Thank you so much. Now we're going to turn to Sari, and we'd love to have you share some insights about your reporting strategies and ideas. But first, please share more about what you learned from your powerful reporting in Colorado. One of your stories chronicles how police investigators came across what they first thought of as a scene of a mass murder, a room full of young adults, all dead in an apartment in Commerce City. How did their overdose deaths occur? And what did these deaths show about the devastating ripple effects of this epidemic on children and families?
So my colleagues and I at the Washington Post wanted to put a face on the staggering numbers of fentanyl deaths and the kinds of statistics that Magdalena just showed us. We wanted to humanize this horrible epidemic. So as Scott told you, in December, the Post ran a 6-part series called Cartel RX. And one of the stories in that series was focused on the people dying from fentanyl. What we're increasingly seeing across the country are something called mass poisonings, where several people at a party or a gathering who are using cocaine, meth, heroin, oxycodone, Xanax, Adderall, all kinds of different things, don't realize that what they're using is laced with fentanyl. And they all die. So we wanted to write about that. And what we did is we filed public records requests across the country in cities where we knew a little bit about, where we heard there had been some of these events. And frankly, we chose a place where we were able to get a lot of public records because that's so key in telling the story. So let's maybe put up the first slide. The second slide, yes, okay, right there. So this event that I wrote about with my colleagues occurred in Commerce City, Colorado. 6 friends gathered for a small get-together late on a Sunday night, the Sunday night of President's Weekend last year. They were all in their 20s and 30s. They had jobs, they were all working, they had families, they had children. Some of them were related. Let's go to the second slide. So here we see Sam Marquez and his partner in front, Karina Rodriguez, while she's pregnant here with her daughter, Aria. By the time of the party, Aria is 4 months old. And I tell you that because during this party, Aria was asleep in her crib in another room. Also in this photo is Stephanie Monroe. So Sam and Karina had the apartment where the party was. Their baby is sleeping. Stephanie is one of the people who came, and she had worked with Karina at a local steakhouse in the suburbs of Denver. Let's go to the next slide. This is Humberto Ledesma, and he was a friend who was also at the same party. His wife, Cora, who was the sister, she was the sister of Sam, who had the apartment. She was also there. And then let's go to the next one. And this is Jennifer Cunningham. She's another friend of Karina's, again, who had the apartment, and she worked with Karina at a local steakhouse. So again, I just wanted to show you those photographs of the people who were at this party. There was a 4th person, Cora, and she actually survived. And we'll talk a little bit about that. So sometime, and we can go off the slides. Sometime in the early morning of that Sunday, last February, the group used cocaine. They also were drinking, they had a little bit of weed, and they all suddenly, after they used the cocaine, they just dropped to the floor. Clearly they didn't know that the cocaine that they were snorting was laced with fentanyl. 12 hours later, the sister of Sam, whose name was Selena, She came by the apartment because neither she or her mother could get in touch with anybody on their cell phones. She opens the unlocked door and comes into this horrific scene of everybody dead on the floor. And the photos of those people I showed you, that's who was inside. Cora, one of the people, woke up. Amazingly, she survived. We don't really know how she survived. Maybe she had used opioids before, and people who have used opioids before have a tolerance for fentanyl. Maybe she didn't take as much. It's just not clear. So my colleague, Meryl Cornfield, and a video journalist, Jorge, went to Commerce City, and Salwan Georges, also a photographer. We went there and we met with the families. And they were absolutely shattered, devastated by these deaths. Some of them didn't even really know what fentanyl was. And we capture that on a video on this story. I saw you have a link to the story and some of the material for this webinar. There's a really good video that really shows the families and how they reacted, and you can get a sense of what they went through and what they're still going through, especially the children who don't understand what happened to their parents, and the surviving parent trying to explain that this was an accident, that this was a poisoning, that their mother or father didn't mean to do this. The local police in Commerce City, along with federal investigators, launched a massive investigation to try to figure out what happened here. And they were never able to link the fentanyl that killed the 5 to a drug dealer and bring charges. So this case has really a cold case. They spent many months on it. And then remember, it happened in February. In September, the police announced they did not have enough to bring charges, that it was too difficult. You know, we don't know how many mass poisonings there have been across the country. In our story, we highlight events that affected African Americans in Washington, D.C. and St. Louis. There are also cases in Nebraska, in Texas, and in Ohio. But law enforcement officials we talked to think that there have been many more cases than have actually been counted. There are not always reported. The federal government does not track mass overdose events, not the Drug Enforcement Administration, not the Centers for Disease Control, not the White House, Office of National Drug Control Policy. What we do know, as Magdalena has pointed out, is that fentanyl is disproportionately killing Black people and Native Americans. In 2020, overdose deaths increased 44% for African Americans and 38% for Native Americans. Switching from Colorado to, which in this case affected several Latino couples, and also, as you saw, a white woman, but actually the survivors were African American, so it really touched on it. It was sort of a very unfortunately diverse event. But my colleagues and I have also visited tribal nations that were hit really hard by the opioid epidemic, and Magdalena gave you some sense of that with the increase in her statistics. We found that at the height of the epidemic, Native Americans overdosed and died at a rate that rivaled some of the hardest hit areas in Appalachia. Across the country from 2006 to 2014, Native Americans were nearly 50% more likely to die of an opioid overdose than non-natives. And this, of course, started with a massive number of prescription pills flowing into these communities. And we wanted to understand more of the reasons why this was happening. And there were 3 main reasons we were told. One is that Native Americans generally have higher than average injury rates from work in industries such as farming, logging, and fishing. They've also struggled with a lack of access to quality healthcare and long-term non-pharmacological treatment options. Again, something that Magdalena touched in her presentation. Also, an audit from the Department of Health and Human Services found that some Indian Health Service hospitals didn't follow procedures when prescribing and dispensing opioids to Native Americans, especially on reservations. And tribal leaders also blame the drug companies for actually targeting their communities. They claim they were saturated by these highly addictive, and fentanyl also is highly addictive, but these highly addictive painkillers. Now, Scott talked earlier about the opioid litigation, and there were 4,000 cities, towns, counties, and tribal nations that sued 24 drug companies, manufacturers, distributors, and pharmacies. And there have been some massive settlements in this case. As part of the litigation, hundreds of Native American tribes agreed to settle after suing these companies, and they settled with the country's 3 major drug distributors. McKesson, who distributed a lot to the Native American communities, AmerisourceBergen, and Cardinal Health. They also settled with the drug manufacturer Johnson & Johnson for, so the total, the 665 million was the settlement. Funds are supposed to go to treatment. Magdalena talked about the problems, the issues with treatment, and funds are supposed to go to addiction treatment and prevention programs over a 2-year period. And this is important. It's really pretty epic. It's the first such settlement of its kind for Indian country. So I've talked a lot. I want to open it up, let people ask questions.
Thank you so much, Sari. Before we open it up, I just want to say I see a few raised hands. What we would like to ask everybody to do who has questions is to go to the bottom of your screen. There's something called the Q&A panel, and type your questions in there, and then we'll share those with our panelists. And while we wait for folks to do that, I did want to ask everybody, this situation seems so dire, and maybe starting with you, Professor Serra, what gives you hope about this? It seems pretty hopeless.
Thank you. Yeah, that's a question I've been getting a lot lately, unfortunately. I think 2 things give me hope. First, we don't see the same rates of overdose across the whole country. We don't see the same trends across the whole country. In fact, there are areas that are tragically highly affected, like we saw with Appalachia and the East Coast. But there are also other areas of the country where we have not seen this huge increase in overdoses. So that to me suggests that actually, right, there are things that are different from these different areas, and that likely provides insights into strategies that we could use to prevent such a rise in overdoses. The second thing that gives me hope is that I think we do have the tools to address this problem. We know strategies that work. We know that harm reduction efforts work. We know that, making naloxone works. So we know that evidence-based treatment works. So I think, we have some strategies that we have to put in effect. I'm hopeful that with the opioid settlement funds, local jurisdictions will invest those funds to increase harm reduction efforts, making naloxone more widely available, providing funding to harm reduction services, including providing social and healthcare services within harm reduction services, making access to medication to treat addiction more easily available, really building on the SAMHSA ruling around methadone and allowing for methadone take-homes, providing more opportunities to distribute treatment in other ways beyond treatment centers like mobile vans, hopefully one day pharmacies. And then I think, the third area is really investing in primary prevention. And so then I know there was a question raised about parenting. We have to really think about what can we do to prevent future addiction? And so, investing in early intervention programs, investing in life skills programs targeted at adolescents, addressing issues of trauma and mental illness that are really some of the common drivers also of substance use. And also, thinking about alternatives to incarceration, again, addressing one of the questions in the chat, thinking beyond the war on drugs and thinking about alternatives to incarceration when we see problems of substance use. So I think there's a lot of strategies that we can put into place. We know what could work. We know that not everybody is equally affected. So hopefully now we can move forward in that direction.
Thank you so much. Before we open it up to the questions, Scott and Sari, did you want to add anything to what Professor Serra said?
Well, I would just add that there's something that gives hope. I think Scott and I have seen parents groups rising up and going to Congress and making this a huge issue. We have met parents like there's a man named Ed Bish who is leading some of these groups whose son died of an opioid overdose. And so that's a positive sign. And these groups and others are working to educate Americans who don't know enough about fentanyl. That is hopeful. And finally, and Magdalena mentioned this, but I think these settlement funds could, they're spread out over 18 years, the $26 billion that went to the biggest settlement. And we need to, there's been a board that's been created to watch where those funds, and I think go, and I think that journalists, it's very important to monitor where these funds are going and are they really getting into local communities? We don't want this to be like the tobacco settlement where the attorneys generals use those funds for everything but treatment. And so I think as journalists, it's very important to kind of watch where the settlement funds go and if they're really going to treatment. But that's a very a hopeful sign.
And Sari, if I could follow that up with a practical question, what would be the best way for a local reporter to check on that?
Well, the funds are being administered by each state. And so they'd have to find the board, the institution in each state. And they're very complicated formulas that were worked out in the settlement for each community, and which had to do with how many people had died in the community, how many people were addicted. So you would need to find out who's administering the funds in your state, also get in touch with the national board that's monitoring this. And I think there are going to be many, many stories in the months ahead about where that money's going.
Thank you. We're going to turn to a question from Katie Brandt. Why doesn't the federal government track mass opioid deaths?
We asked that question especially to the Drug Enforcement Administration. I think Scott might have asked that question to the White House, so he can address that. But it's just something under there. I mean, the reason that we were able to find some of the cases that we found were just basically Googling and looking all over the country at local news reports to see where 3, 4, 5, 6 people had suddenly died in a mass event. They just don't track it. There's no database to go to. I don't know, Scott, do you want to add anything on the White House aspect of that?
Well, just, the federal government overall, our investigation found has been kind of behind the ball and very slow to respond on lots of different fronts. This included in terms of tracking mass overdose deaths, but the CDC is a year behind in tracking deaths in real time. There is something called OD map, where there are a bunch of health departments and medical examiners around the country that are trying to fill in those gaps and trying to determine where the overdoses are taking place so they can get resources to those communities. But that's kind of scattershot, and not every health department, not every medical examiner's office is taking part in it. So it's really patchwork. And so they're slowly catching up, but looking at deaths that took place a year ago and trying to predict what's going to happen on the ground next month is almost impossible. It's like one of the former drug czars we interviewed said, it's like trying to track the overdose epidemic by visiting cemeteries, and it just doesn't work. So the federal government really needs to kind of step up its game.
And I'm seeing a couple of questions here that are really asking about how people get local data, which of course you've just spoken to the flaws there. But Ruben Tapia of Radio Bilingue is asking, do you have data about how the crisis affected California Central Valley? I'm assuming you would point him to that OD map, as imperfect as it is. And then we have another question from Anne Marie Cunningham saying she's in Mississippi. Was a Mississippi band of Choctaw Indians part of the $665 million settlement? Where would folks find, similar kinds of data for their markets?
Well, the OD map, and this is another problem, it's not public. And they they would not grant us access to it, even if we, and we signed, we offered to sign agreements where we wouldn't disclose any personal information of any of the people who had overdosed, but they still would not share it with us. So that's a problem. There is open source material. Sari and I, along with about 50 other reporters at the Washington Post, did an investigation called the opioid files. And if you just Google that, you'll see there's a landing page. And on that landing page, it says something like, track the data in your community. And you can find out through that open source website that we created, which manufacturers made how many pills and which distributors distributed how many pills and which pharmacies dispense how many pills in your particular county. It's a county by county database, and it's really an incredibly powerful tool. It helps to see where all the drugs came from. And then the other place I would check is your state health department. Depending on the state that you're in, they have enormous amounts of data, and a lot of it is publicly available. Like Magdalena could probably talk about that because a lot of her material comes from those health departments, correct?
Yeah, so I would say, yes, exactly. Checking the state health departments, the city health departments often actually have even more detailed data. And often the state and local health departments will have dashboards where you can track trends over time, potentially sometimes download data. So for example, for California, I would check the California Department of Health because they do have a dashboard. And then the CDC website also provides more national data. So I think those would be the main places. But yes, I think, outdated data is certainly an issue. And I think this really became more apparent with the COVID pandemic, where we saw that actually having outdated data was not necessarily inevitable, right? We could have more real-time tracking of a disease. So I think this really points to the need to provide more updated data for overdoses. I do have hope that we're moving in that direction. And I know the CDC is actively working in this area, and local jurisdictions are as well. We're doing some work in Rhode Island to predict overdoses that are going to happen in the next year. And we're not the only ones doing that, but this is really an area that requires a lot more work.
And on the Indian Nation question, hundreds of Indian nations were part of the litigation. I think someone asked about the Choctaw Nation. Choctaw Nation of Oklahoma definitely is part of the settlement. And that's a place that we visited. I don't know. I think, did she say Missouri? I'm not sure. You just have to.
Yeah.
But the Choctaw Nation, at least in Oklahoma, was part of the litigation and did get settlement funds.
So we have a question that you're already all sort of touching on, addressing, but the question is from David Hernandez, who says, what are the challenges and issues in the investigations into overdoses, such as police investigations?
Well, I mean, Sari could probably talk to this because she tried to get records from Colorado, but it's state by state. I mean, some states are really great with their public records laws and you can get access to all kinds of material, and other states are terrible. So, I mean, I used to work at the Miami Herald, and, the mayor's mail is a public record in Florida. So that was a really fun place to work. But in places like Maryland and New York, the rules are a lot stricter. So it's state by state, but there, everybody has a public records act in every state, or a Freedom of Information Act. So I would use that heavily. And then a lot of medical examiners' offices in states, their records are public, like in California. Every overdose file, every medical examiner's investigation is a public document, which helped us enormously when we were doing our investigation into overdose deaths in San Diego. And they have spreadsheets of how many people died, the ages, and you can run that data all different kinds of ways to find out what are the age groups, what are the demographics, where was the geography. And so you can get very granular with that kind of data.
Right. I think one of the first things to do if you're doing an investigation where you want police material is file the public records request, because in our case, we didn't get even answers from many of the local jurisdictions, but Colorado released everything. I mean, they released the police record of this case. And so you'll see, if you read our story, there's, details about where everything was in the apartment and, even what the people were wearing. That's all in the report. So we were lucky as reporters to get that kind of information.
We have a question from Edwin. I hope I'm pronouncing your name right. Edwin Nayako Nayasani. Most Native American tribes do not have the public health infrastructure to offer the treatment and social services needed by these communities. What is being done to improve these disparities?
Yeah, that's a very good question. It's a little bit beyond my area of expertise. I do know that there, at a general level, that there are efforts, of course, depending on the tribe, but there are a lot of efforts to invest in, particularly in access to evidence-based treatment. Actually, if you look at the data on access to evidence-based treatment, American Indian and Alaska Natives do have access at a comparable level to whites, whereas Blacks, Latinos, and others have less. But I think there's still a huge way to go. As Sari mentioned, I do think hopefully with the opioid settlement funds, particularly given to specific nations, there can be a lot more done in that direction.
We have a question from Terry Langford. Hearing a lot about Black and white and Native American opioid use. What about Hispanic communities? And then Terry goes on to say, along border states, we have political officials who have now latched onto fentanyl use to bolster their anti-immigration efforts. How do you tease out those two subjects and find where the anti-immigration war is falsely using or hiding behind fentanyl?
Yeah, I think one has to be really careful when we're seeing these disparities, right? Well, two things. One is we are seeing increasing rates among Latinos, not as high as for Blacks and American Indian Alaska Natives, but they are increasing. But one has to be really careful when one looks at these disparities to not take a blaming approach, right? In fact, it's a very different phenomenon, people dying from overdose and the drug trade. And so it seems like a completely false dichotomy to connect the two. But I can see how that can become a huge political issue on the border.
Yeah, and the other myth, I'm sorry, Sarah. Well, the other myth about this and spending a lot of time down the southern border, you see this. The vast majority of fentanyl is being smuggled through the official ports of entry. So San Ysidro, Nogales, Otay Mesa, these giant ports where you have 100,000 vehicles coming back and forth every day. And so it's not an immigration issue. I know that there's lots of people out there that would like to turn this into an immigration issue, but the wall has nothing to do with this. Very little of fentanyl is being carried by people. It's mostly being stuffed into cars and into trucks by drug trafficking organizations, the cartels, and by their smugglers, and just driving it right through the ports of entry. So I know people are clamoring for, shutting down the border and building more of the wall, but that's not the answer to stopping fentanyl from coming into the country. And it really has very little to do with immigration issues along the border.
Sari, were you going to add to that?
That's exactly what I was going to say. We're mind melded.
And
Yes.
Gabriel Kelly says, how do you balance the need to report accurate, true information with the right to privacy for the families and loved ones of the affected?
Yes, that's a really good question. Whenever we do the kind of reporting like we did in Colorado, we try to be really sensitive. We're very careful about how we approach the families. In that case, my colleague and I, Meryl Cornfield and I, contacted the families, told them what we were doing, asked them if they wanted to be part of this reporting and if they wanted to talk to us about their loved one who they lost. if they agreed, and if they didn't agree, we didn't push them. If they did agree, we met with them. And when we met with them, we spent a lot of time, hours and hours, and we agreed to tell them before the story ran exactly what was going to be in about the family and the person who had died. So there were no surprises, and they knew exactly what we were using. In the case of one of the families, I think I talked about Aria, the little 4-month-old girl who was left without both her parents, and her grandmother and her sisters are taking care of her. They did not want her face shown, and they wanted to see the photographs that we were using beforehand, which we did not have a problem with. And so we basically work with the families on a story like this to let them know what's coming, because it's very difficult for them. They have to relive the trauma of what happened in telling us the story, in telling the video journalist the story, in telling a separate photographer the story, and then having it be in the paper. So we just try to be as sensitive as possible with what they're going through.
So officially our time is up, but I'm hoping that you all can stay for maybe another 5-10 minutes because we have some questions here in the queue. We have one from Karina Romero asking which states do not honor Good Samaritan laws. Is there a database that Karina and others could look to?
I think there might be maybe 5 states that don't have Good Samaritan laws at this point, if that. Most states have a Good Samaritan law, but again, they vary widely in terms of the protections that they offer. The best resource is either Law Atlas, lawatlas.com, or PDAPS, pdaps.com, which is the Prescription Drug Abuse Policy Surveillance System. These are both databases run out of Temple University by Scott Burris's group, the Network for Public Health Law, and they provide you can actually map out what protections are offered by each state. So I would recommend either going to PDAPS or Law Atlas to get that data.
We have a couple of questions about public records, and one, what public records have you found to be the most revealing in your reporting, and another asking, which ones you use. I don't know if you all could quickly touch on that more than, some of the other stuff you've shared for Sari and Scott.
Well, there's a great resource that's been put together by the University of California, San Francisco, and Johns Hopkins. It's a compendium of all the documents that have come out in the litigation. The Washington Post got millions of those documents unsealed. We filed a legal action in the court case involving those 4,000 lawsuits that we talked about earlier. So internal emails, company documents, audits of their programs, all those documents are available on our website, but also on that Johns Hopkins University of California, San Francisco website. And then all the bankruptcies. So all the documents from Mallinckrodt are all in there. All the Purdue Pharma documents are in there. Johnson & Johnson documents, Walmart, CVS, from all the trials that have taken place. So it's an amazing resource, and you could use that information to localize your stories to your region of the country, to your state, to your community, to your county, to your town. It's just a great place to start. And then, we talked earlier, about the medical examiner's office, the state health departments, the city health departments. Those are all great resources. And there are a lot of people within those departments who I think would be more than happy to talk to you and point you in the right direction on how to do this.
And I don't think we mentioned that the Washington Post, with the opioid files, put together a database that is open to the public, where a journalist or anybody can go into this database, put in the name of their city, and find out which pharmacy dispensed the most opioids, which distributor, which manufacturer. And many journalists have already used that to write stories about their local communities. And we wanted to get it up there so everyone could use it as a resource.
Thank you. We have a question from Sheila Sid, who thanks all the panelists for their research and reporting, and asks, how do we engage communities and share insights on mass deaths and access equity?
So that's-
Is this a question from a journalist?
I think it's probably from a non-journalist is my hunch.
I think there are multiple ways to do that. You know, it can be done at the government agency level by engaging with the health department, which I think is really the main driver of the opioid public health response in local areas. But it can also be done at the community level, particularly by engaging with community-based overdose prevention organizations. So there are a range of harm reduction services that might be available in local communities, places that, you know, might do anything from just distributing naloxone and distributing syringes to providing healthcare and social services for people who use drugs. There's also, you know, there's also the possibility to do a school-based response. So I think, you know, a health center-based response. So I think it's really thinking through what the main actors might be for our response, and particularly starting with those who are most engaged, I would say like harm reduction and the health department.
So a question from Brian Rinkler for Magdalena. Can you talk about conservatorship laws and safe injection sites as strategies to address the overdose epidemic? What are the pros and cons, and what does the research say to their effectiveness?
So safe injection sites or safe consumption sites are sites where people can consume drugs under supervision. And in that way, the idea is that, first of all, people will have the opportunity to get help in the case that they overdose. They may also be helped in terms of figuring out safer injection and use practices. And they may also be connected to other services if they're interested, for example, in getting into treatment or engaging in healthcare and social services. So far, about 160 countries across the world have safe consumption sites. It is in the United States, the first 2 sanctioned consumption sites have opened up in New York City, although there are unsanctioned sites in other places across the country. The data from other countries suggests that these sites are effective in terms of preventing harms from overdose, harms from drug use for people who use drugs. And also they're not associated with an increase in problem in surrounding communities. I think we really need to figure out how they work in this country. This is a different country from what, you know, the countries where these centers have opened up. But I do think there's a lot of hope for these centers to be one of the tools that we can use to prevent overdoses and other drug-related harms.
We have a question from James Pollard. Is there any data around the impact of fentanyl trafficking and drug-induced homicide laws on overdose death rates and the fentanyl supply?
Good question. I don't know the answer to that.
Yeah, I haven't seen good data on that, but this is a very controversial thing, these laws. This is something that came up in Colorado. They didn't have such a law after this incident I talked about. The legislature passed a law and the governor signed it. At least 23 states and Congress have passed similar legislation, which increases the penalties for dealers whose drugs kill users. There are those who oppose this, and we saw that in Colorado. There were legislators, there were activists who fought this bill, even though the DAs, U.S. attorney, everybody was supporting it in law enforcement. Activists fought it, saying that they thought it furthered the failed war on drugs, and it targeted people of color. It sent people struggling with addiction to prison rather than providing treatment. So these laws are controversial, but I haven't seen good data on them.
You'd probably have to go like, municipality or, region by region, because I know this is a big thing in Southern California also. And we actually followed a guy who was trying to make those connections between people who had overdosed and then trying to trace that back to the person who sold them the fentanyl. and you have to prove that person knew that what they were selling was fentanyl and not, coke or heroin or some other drug. So I would imagine, like, if you were to call the San Diego district attorney's office, they would probably be able to share data with you in terms of prosecutions, how many charges were filed, what were the result of those charges. So it would be a little time consuming, but you probably have to go like county by county or city by city to find that data.
And the same resource that I mentioned before that has data on Good Samaritan laws also has data on drug-induced homicide laws. I think one of the big controversies with these laws is that while the idea is that they will help convict people who are, doing high volume drug trafficking, in fact, they mostly target friends and families and low level consumers of drugs. And so these are particularly problematic when we think about the fact that we want to encourage people to call for help in case of an overdose. We're starting to look at the impact of these laws in terms of overdose rates and hope to have findings very soon to report.
So your schedule permitting for all of you, we have two sort of huge questions here that go beyond what a lot of the things we've been talking about, not necessarily journalism questions, but let me just sort of give them a try here. After the murder at the hands of police of a young Black man in Memphis, who the police said was using drugs, are you for ending the war on drugs, which is a war on people carried out by the police and Drug Enforcement Administration? That's a question from Helen Redmond.
Well, it sounds more like a statement than a question, but I think if you talk to the men and women who work at the DEA or Homeland Security investigations or any of these law enforcement agencies who are working along the border or at airports, et cetera, will tell you that the war on drugs is a total and complete failure. They'll be the first ones to tell you, even though that's their job. And their job is kind of morphed into trying to save lives with Narcan, like you saw in that video. That lieutenant spends his whole night basically trying to save people. And so the job has really changed a lot. It sounds like a cliche. You hear it from cops all the time. They say, we're not going to arrest our way out of this problem. There's no way we're going to be able to stop fentanyl from coming into this country, that we have to stop the demand. You're not going to stop the supply.
And one, Magdalena, were you going to say something before I turn to our final question?
No, I would say, that there are interesting examples that we and I hope all of you should be tracking, which offer alternatives to the war on drugs. And so for example, that's Oregon M110, which decriminalized the low-level possession and use of all types of drugs. And so that really speaks to, alternatives to incarceration for drug use. I know we're currently evaluating the impact of M110 on policing and on overdoses. And I think, as this increasingly happens, hopefully across the country, it'll be important to track how that's affecting the overdose crisis.
Well, if you look at other places around the world where they have changed their laws, like Portugal, drugs are basically legal and they have one of the lowest, if not the lowest, overdose rate on the planet. And so that is something that we might want to pay attention to.
We'll have the final question here, and I appreciate everybody's willingness to stay a little longer. From David Dooley, he says, many substance abusers experience unsupportive, and again, this is going in a different direction, and harmful parenting. If we want to prevent substance abuse, we must find ways to improve the overall quality of parenting. Should public health authorities be developing an entirely new kind of parenting education that reaches everyone, everywhere?
Well, I do think that speaks to the role of primary prevention, right? So one of the recommendations I have is around investment in early intervention programs. So early intervention programs, particularly those that are done with the involvement of the local community, such as nurse home visiting programs, preschool programs, they've found to be effective in terms of reducing risk behaviors and early initiation of substance use. So I do think that there is a role for such programs focusing on parenting, but again, in a non-punitive way, that reduces racial and ethnic inequalities in punitive approach to parenting and is done with the community, I think should be an important tool in this response.
Thank you. Well, I want to thank our panelists, Dr. Serra, Scott, and Sari, and to the audience for all of your great questions. I'm sorry we couldn't get to all of them. I want to offer our thanks to contributing editor Fran Smith, Ryan White, our content editor, and Cassie Garabay, our engagement editor, all here at the Center for Health Journalism for their work to help produce this webinar. And we'll be sending everybody participating here a survey asking for your feedback on today's program and for your ideas and other topics of interest. Please take a moment to complete it. We also urge you to help support these webinars. You can find information here on how to do that. We'll be archiving this webinar a little later today at centerforhealthjournalism.org. Thank you so much for joining us and have a good day.
Thank you.
Thank you so much.
Thank you, guys.